morning.
Good morning.
We'll call the meeting to order. This is the State Consumer Health Information and Policy Advisory Council, the SHIP. It's Thursday, September 21st. And I'd like to welcome everybody, folks who are online, the folks who are here in the room, and looking forward to a really good and productive meeting. One thing I want to do right after the roll call is pull up from the agenda, if it's okay with everyone, the DCF update, because Molly may need to step away at some point, and while we have her in the room, to get that update. So is everybody okay with that slight change to the agenda?
Molly.
For Molly? Yeah. Okay.
Say no, she has to stay.
I think she'll leave anyway. So anyway, all right. And everybody can hear okay online? That you can tell?
Jamie said
Yep,
that.
okay, great, thanks. All right, Crystal, will you do the roll call, please?
I can.
Before that, just a reminder for everybody online that the meeting is being recorded. So you need to let folks know that it is being recorded.
Thank you. And actually, part of my welcome should also be that we just learned that it's Angelia Rivers' last meeting. So we want to thank you very much for your service, and we're going to miss you. Anything you want to say?
It's been a pleasure. It's been a pleasure. And I am retiring. So
Good for you.
5 years.
Congratulations.
All right, we'll get back in the group here. Yeah, Crystal, if you would want to do the roll call. Thanks.
All right, so Angelia Rivers.
Present.
Joyce Case. She's not on. Diane Godfrey.
Present.
Lindy Kennedy. Is she online?
Lindy, are you online? And Crystal, I'm not sure they can hear you if you don't have a mic. You know, for the folks who are online. Oh, is that what they can?
Yeah, the mic. Can you guys hear me okay?
Yes, we can hear you okay, Crystal.
Perfect, thank you. She's not on. Okay, Dr. Shapiro,
Here.
Karen Van Callo,
I'm here.
Molly McKinstry, Dennis Hollingsworth, and Gerard was not going to be attending. Gerard's not on, correct? Or Jared, sorry.
We need one more member.
I need one more member.
I have here the hand raised 850-445-27. I don't know.
So can you unmute whoever that is? Be a member.
To get to forum.
Crystal, this is Alexis Bukowski with the Office of Insurance Regulation. I'm on the line.
Oh, perfect.
Great,
Thank
you.
thank you.
Alexis. Now we have a forum.
And Crystal, Bruce Culpepper and Michael Craig are on behalf of DOH. Dennis Hollingsworth is actually at the same event I'm at.
Okay, thank you.
All right,
All right.
thanks.
We have a quorum.
Terrific. All right, so you were emailed the minutes from our last meeting. So did anybody have any corrections to make? If not, we will appreciate a motion to approve them. All right, from Dr. Shapiro, a second. Second. From Molly, any discussion? All in favor say aye. Any opposed? All right, motion carries. All right, so we have a lot of action items from our last meeting, so I'm going to go through an update. So I think it's going to be a tag team effort, right, on the update, or?
Are you doing that or Jamie?
Jamie's going to do that? Okay. Jamie, you can take it from here then.
Thank you. So just to go over our action items from the last meeting. First item was to look into seeing if some reference material on the website could be provided in Spanish. We did take that and look at that and spoke with the leadership about that a little bit more. Currently, the agency is not moving forward with this. we do understand there is a need for that, but I think a little bit of the concern is misinterpretation, especially when we have forms that are put out there by rule. We do understand there are some organizations that are translating their forms internally, but at the moment, we're not going to be pursuing that. Perhaps down the road, we may revisit. Second item was staff to work with representatives from the Department of Health and DCF to determine the need for collecting Social Security numbers and bringing recommendations back to the advisory council meeting. We did meet with members of the Department of Health, and they are going back and looking to see what sort of progress has been made in the past. This does touch in multiple areas and multiple programs at the Department of Health. And so they were going to go back and see what they've done and how they've addressed it over the last couple of years, and will report back to us soon. I think Ms. McKinstry is on from DCF. I'm not sure, we have not met with DCF specifically about that. Molly, I don't know if you may have any insight to that, or if not, we can kind of speak about that later at the next meeting.
We do. I got with our team and, we are on the precipice of doing a lot more connectivity with data across multiple agencies. When we go over the legislative updates, I'll talk about some of the opioid funding and the data needs to really look at how clients are served across multiple areas, and our team had some significant concerns about getting rid of the Social Security number. I know that's a challenge, but when we are looking at data across multiple venues, we want as much assurance as possible that a person is the right person we're trying to combine information. So just wanted to share that with you. Thank you.
And Jamie, this is David Shapiro. I had a question also. Is the fact that it's still pending, which I appreciate, does that in any way alter the previous proclamation that you made to us on behalf of the ASCs for their quarterly reporting, where it was now not going to be flagged if there were no Social Security numbers or very few?
No, this does not impact that previous decision and how it impacts the ASC's free reporting.
Great, thank you.
Jamie, Karen.
Yes. Thanks.
Clearly I've not had enough coffee today, so can we go ahead? Long drive from Orlando. Molly, could you just jump in and do the DCF update? Do you have anything further than the Social Security? I don't know if you wanted to jump in there.
Legislative update?
Yeah, do you mind? I know, because I know you got to run out, and I'm sorry, I said we would do it, and we'll pick back up with Jamie. I know you might
That's
get
all right. Sure.
a call to run out of here.
Okay. Sure. So I think I was just going to try to stick with the things that would be relevant for this group of most interest. And most of them are probably related to budget issues. So we did receive funding to implement, after a long wait, electronic health records for our state hospitals. So we're a little behind the curve on that, but we're excited to start that journey. And so we'll be working on that. What system? We'll be procuring a system for that purpose. We also got a $1 million appropriation for electronic health records for foster children. And so that's a small piece, but we do think it's a pilot project and designed to really target, as foster children. Foster care program. So we'll be working on that. We received, we did transition. I know this may not be of a big interest to many folks, but there were 7 counties where the child protective investigations were done by the sheriffs, and the state and those have been transitioned back to the department. We received additional funding for staffing at our state. The opioid settlement agreement resulted in our ability to fund a opioid council, which will be administered in conjunction with the Attorney General's office, and there's some funding, I believe, 5%. Talk about is $5 million. It's technology. So, we've been really trying to work on a 360 view of individuals that we interact with the department, and expect that we'll be doing more of that with other agencies. So that gets to the point of making sure that we have as much information as possible to make sure that we've identified the right person across those systems. There's also funding for a open bed or bed availability system in the mental health and substance use space, mostly substance use, but that will be procured as well, and is intended to provide better access to the availability of resources for families or healthcare practitioners that are looking for substance use beds in the state. There was additional funding for a data system for homelessness and housing information. So right now, those systems exist at the continuums of care around the state, and this will give us some consistency around the state. We continue to modernize a couple of our major systems. Our child welfare system, we'll receive year 2 funding of that. So that's how we track our the families that we work with in the child welfare system. Many of which, intersect with ACA. Most of those kids are under the Medicaid program under the child and Department of Health under the Child Welfare Managed Care Program. We're modernizing our eligibility system, the Florida system. So this is where we do all eligibility for Medicaid and other public benefits. We receive year 2 funding for that. And of course, have a strong connection with ACA, especially since it's a Medicaid eligibility component of that. It also blends a lot with some of the modernization that ACA is doing through the FX project. Let's see. Let's see if there are any other big ones there. I think that's probably the biggest budget issues. From a policy perspective, I mentioned the statewide council on opioid abatement. So they'll be having their first meeting next week. So we'll be working closely with the Attorney General's office on that. Shared transition. There was some funding and policy issues related to jail-based competency programs. So for individuals that are incompetent to proceed that end up in our state mental health treatment facilities for competency restoration, the ability to work with jails and help people receive treatment before they transfer to the state. That also may help in some cases with hospitalization issues as well. Because I know some of those individuals end up staying in hospitals a little longer waiting for hospital beds at the state hospitals. And we did receive additional funding to support additional capacity in the state hospitals as well. Okay, I would say those are, there's a little proposal about recovery care homes, but I'd say that's probably not a major issue. That's mostly for substance use programs. That's basically all the updates on that might be helpful. So, all right, thank you for letting me go.
Thank you. Any questions for Molly? That was a lot, but for the folks who are not here in the room, she has many pages and she's flipping through. She's got a lot of other things going on. Right, the Reader's Digest version. Any questions for Molly? All right, well now when you get the call, you jump out of the chair.
Okay.
All right.
Thank you for that.
All right, well you could anyway. Thank you, everyone. And I'm sorry about that. Jamie, we'll let you get back on track.
No problem. Thank you. So the next action item was to investigate sending email blasts and communication to licensed behavioral health providers in Florida to encourage them to get more involved with the health information exchange services and learn more about that as a resource. And we do agree it's a great idea. As you guys are aware, we do have as part of our agenda item this transition that we're facing currently. And so we're going to hold off and wait until this is a little bit more defined and further down the road before we can before we want to move on with that. A lot of moving parts, and I think we'll get into a good discussion about that a little bit later. Next item was to reinstate the legal work group, which has been completed. Legal work group actually will be meeting on October, I believe, October 10th, from 10:30 to 12:30. Next item was to refer the issue of allowing access to HIE data by users in Canada in the ENS agreement. This and some other items will be brought together before the legal work group for their next meeting to also discuss. Next item was for staff to meet with national organizations that connect quality data to consider what may be beneficial to add to the transparency websites and bring any viable or valuable information back to the council members. We had staff to meet with Leapfrog about their data sets. The team will continue to look at other organizations and how they receive data, and if there's any certain data that would be valuable to add onto the Florida Health Finder website. The only issue that we're facing at times is that the data may be voluntary, and so these resources may not have a full picture. So we're going to be cautious as we kind of continue that, but anything that's worth value, that's worth bringing back to the members, we will definitely do so. I think the next item was to plan an all-day meeting or retreat for the advisory council members to develop their goals and planning for future efforts. This is still pending. As we get more information down the road, we'll definitely share it with everyone. Next item was to see if ambulatory surgical center measures page could be renamed to outpatient surgery measures page, since hospital outpatient data is included in these measures. This is something we won't have a problem doing. We just have to work it into our next contract with our vendor, which we are currently drafting and routing. So that'll be forthcoming soon. Next item was to check with organizations to get input from potential users for other suggestions for improvement. That's been completed. Check on the feasibility of adding the locate facility button on the new transparency landing page, as well as maintain this option for the Florida Health Finder page. So we have a combined button for the compare and locate, and I'll be doing a little live demo of what that website currently looks like. It is currently in test. We did roll it out live shortly to do some testing under live environment, but we don't have just still shots like we did, I think, a while ago. We'll show you how the functionality of that website is looking, and we would love to hear some feedback on that we can maybe incorporate into our next phase of updates. Next item was to determine how the annual report on Florida Price Finder can be more visible. That's been completed. We do have a button out there. Just keep in mind that when we do have Florida Price Finder, we talk about that website, that vendor does not have technical teams. They're more of data scientists and analysts, so they have to contract out. At times, that's what's kind of the holdback. Even if it may seem that a change may be very quick and easy to make, they at times have to get that resource in-house before they can move forward with that. Add the topic of including self-funded data to the all payer claims database to have more inclusive data for the Florida Price Finder page. That's currently still pending. Next item was to include a static note on My Florida RX website to make clear the asterisk denotes generic medications. That is in process of being made currently. Next item was to look at regrouping the sections on the new My Florida or the Florida Health Finder homepage by users, such as like grouping things under the consumer tools or research tools, grouping that together. We'll show you guys what that looks like a little bit later in the agenda. And again, we'll be open to feedback and then seeing what we can do in the next rendition of updates. Next item was to consider moving up the facilities, services, and characteristics so that they display on the first page, since facilities in numerous locations may push that information significantly lower on that provider profile page. This is something we're going to look at and consider that for the future phase. Restructuring that, the way the framework is set up, is going to be a bit of a lift. So we'll discuss that with our vendor when we start scoping out all the details of what's going to come on going to the next phase of those updates. The next item was post-transparency update slides to the website. That's been completed. Next item was to include a legislative update from DCF on the next agenda. That's been completed as well. And I believe the last item was or the next item was to poll members to see if the December meeting should be moved to another date. That's been completed. And I can see here there's one more item, check on the feasibility of adding the locate facility. I think I covered that a little earlier already. I believe that completes all of the action items that we had pending in their updates.
Thanks, Jamie. A couple things. The actual slide that we're looking at is not the most updated one, because you did say self-funded, but on that line, it says add a topic of including self-pay. So it's a big difference between the
Okay,
two. So just want to note that as people are looking at that. And then up with the email blast, I know when Diane mentioned this, it was specific to behavioral health, and you may have said that, but that row just says email blast to licensed facilities. It was a behavioral health discussion. So I know we had updated it, but just if we could swap that out for the record, that would be really helpful. And then right before the meeting, we were talking about this retreat, and with Angelia retiring, and we do still have a couple of vacancies on the advisory council. We want to wait until we have those positions filled, so we have the input from those really important constituents. So hopefully we'll be able to do that in the first quarter of the new year. We're not going to be able to obviously make all of that happen with trying to get people's dates and positions filled before then. So just definitely stay tuned on that. Does anyone have any questions for Jamie on the update? Any questions online that we can see? Does anybody have any? No? Yeah, just follow if anything comes up. All right. Terrific. Thanks so much. And I guess, well, Jamie, are you also going to go ahead and do the Florida Center update?
I think we have the agency. I'll do the agency updates. Yes, I'll do the agency ones.
Okay.
So few little quick updates for as far as on the agency side. For Hurricane Idalia, the agency did activate and staff the EOC Emergency Operations Center. The agency conducted 236 on-site post-assessment visits with all of their field staff and handled 2,645 calls to our licensees before and after impact. On the emergency patient lookup site, as far as some highlights to share about that involvement and activation for Hurricane Idalia, we had special needs shelter encounters originating from the special needs shelters that reached 68 unique providers and health plans. And this helped essentially close the gap in care coordination during that disaster and during impact. Publix pharmacies executed the SureScripts addendum. This allows the sharing of that pharmacy fill data with E+. We also had 38% of the special needs shelters that opened for Idalia, for Hurricane Idalia, had access to E+ to query for medical records and medication fill histories. And E+ was working with Humana to locate. We assisted Humana in locating some of their missing members. Ultimately, we helped them find 100% of their members that were evacuated to an E+ enabled shelter. So it was good to see. I will share we didn't stay activated too long. Luckily, where Idalia hit, it was not too much of an urban area. There was still severe impact in those areas, but a lot of our facilities were not in direct impact. And so activation didn't last as long, but E+ was activated. Staff was working around the clock to just support either users of E+ or those who wanted to use it as a resource. Again, just as a reminder that E+ is activated during an emergency order. We essentially need that in place to do. And as soon as we get the order, we are in communication with our leadership to make sure that E+ is staffed and available for use. That completes the updates on the agency side. Any questions?
No questions online either. Thank you, Jamie. So I guess you're going to go right into the Florida Center unit update too?
Yes, I think I believe Udin. I believe Udin has those to cover.
What was that, Jamie?
I believe Udin was covering the Florida
Yeah,
Center
okay, yeah, I
updates.
just said on my notes that you were, but we're good now. Thanks.
No problem.
You guys hear me well? We're attending online.
I don't think it's on. Because this one is on. You have the switch on the bottom here.
Hi. Yes. Hi, my name is Muddin. I am the HA contract manager here at the Agency for Healthcare Administration. So I'd like to give you some updates regarding our units. First, I will start with Office of Data Dissemination and Transparency. You have heard some updates from Jenny earlier about the Florida Health Finder website updates. So the overall goal for the website update is to change the look and feel, in addition to providing consumers with new navigation options. And we are also updating Florida Health Price Finder website. Care bundle implementation is currently underway, which is supposed to be completed by fall 2023. The agency vendor audited about 150 care bundles and added about 100 new care bundles. And overall, the agency expects to be the total care bundle as 390, pending formulation just in 2023 Q4. We are also working on to develop marketing and outreach content, and it will be finalized right now. But it will be published in coordination with the Go Live for Florida Health Finder. Slide. Okay. Now, a couple of updates on Office of Data Collection and Quality Assurance. The unit has completed the certification for data collection for 2023 Q1. Unknown social security number requirement. Sorry, yeah. So, okay. An unknown social security number threshold edit has been suspended for all ambulatory surgery centers. Yes. So now some updates regarding Office of Health Information Exchange. First, I would like to share with you some activities that took place in our unit, Health Information Exchange. We contracted Health Tech Solutions in April, and the contract started on April 18 and ended on June 30th. The vendor, Health Tech Solution, interviewed rural healthcare facilities and developed an environmental escape of the agency. And they identified some needs. For example, the opportunity to support the broadband opportunities that are available through the Florida Commerce, and opportunities to support the Pathway to Prosperity program. As you know, this program was initiated by the Florida First Lady, Casey DeSantis, in 2021, and Department of Children and Families is the leading agency to implement this program. And we are closely working with the DCF to support this program. The vendor also recommended to create cross-agency collaboration and to support the rural healthcare providers. And the agency, they said, should include Department of Health, Department of Children and Families, Agency for Healthcare Administration, of course, and there are some other state agencies. So I'm not going to provide an update on E+ because Jenny already shared with you update on E+. Next slide. Next slide. No, we are not going to share the update because Jenny already shared update on E+.
Can we go over the slide anyway?
Yeah, sure. So E+, as you may know, this is emergency patient lookup system. It's a platform which helps to support care coordination during times of disasters. It was deployed in the hurricane, due to the time of Hurricane Italia, and 39.5% of special needs shelters had access to E+, and they were able to query the clinical records through the platform.
Do you know why only 39.5% had access?
Yes, so that 39.5% in all the shelters that use the E+, all the shelters that were deployed during the hurricane, only 39.5% have access to E+ to query clinical records.
So for, any user of that system has to be trained on the system and has to be credentialed. There are some, counties that have not been, credentialed or agencies, within Florida that have not been credentialed use, to the system. So part of the number is based on there were folks that just didn't have the training and access to the system at the point when it hit.
So what are the
Can you
barriers?
use your mic so folks can hear you online?
I mean, great point. I was going to ask the same question. So what are the barriers? Because obviously we want this to be a lot closer to 100%, preventing those counties from getting someone registered on the system.
So every county is set up a little bit differently, and the responsibility, although the special needs shelters are usually operated by, or the staffing in those special needs shelters are operated by Department of Health staff. There are many counties where the operation and implementation of those special needs shelters are through other entities. And it really is just staff getting out there. Our staff, we do have a team that is working to reach out to every single county, learn how their infrastructure is set up, because it is very different in every single county, and getting to the right folks so that we can get the right people trained and allow them to have access to that system. We're making really great headway. I wish we probably should have put the numbers in there of counties that we have covered. So we are seeing successes and more counties that are utilizing the system, and varying agencies within those counties that have different access. So not only, I mean, we want the special needs shelters to definitely have access to the medication history and patient records, but we also want folks in other emergency response teams to be able to use missing persons to help locate individuals that may have been transferred to a hospital. And we can provide that information if they're not looking for someone that is not really lost, right? We know where they're at. So it really is just a matter of learning how an individual county is established and who we can work with.
Question. How do you pitch the value proposition to the counties? Do you talk to them about why it's important? Do you think that's understood? I know a lot of the things in an emergency is kind of chaotic, right? And so, but I mean, during blue skies, is that part of the conversation?
Absolutely, and really, it's really important to get to them before there's an emergency, right? We were very fortunate during Ian that some of the first counties that had gotten trained and utilized the system were those counties in that area that got hit. So we're very fortunate in that. So, in those individuals really it's kind of a tight-knit emergency response community. And so those people that have utilized the system, sharing their stories and the benefits of it, I think has been very helpful. We're going to have one.
So how are they managing access to the system once a county or a special needs shelter has access to a system? I would assume they have individuals that come and go as well. And because access to the system is access to a lot of PHI.
Right. So it's a tier process. So we do provide access to one individual that is. And access is only granted during an emergency. And so during that, outside of an emergency, folks cannot get into the system. They can't get access to that PHI. When there is an emergency, we do have lead individuals within, like with the special needs shelter, whoever is over the special needs shelter, that individual can then credential their folks within that facility. But we do have to have a listing of all of those individuals with their credentials. Are they an RN? Are they, they do have to be medical providers who have access to those records.
Did we ever audit, is the system ever audited for appropriate use?
Yes, we do have that capability to go in and we can actually see who has logged in, who they've looked information up for. And so we do that within every disaster and then immediately after. So we do know when we do audit.
And we were pulling that multiple times a day.
Yes.
I'm sorry, say that again?
We were pulling the information a few times a day to see who had logged in and what they were looking for.
And I got one more, actually a couple, but what are we using for identification? Are we back to the social security numbers in the system?
Okay. So we actually use the similar identifiers. It is not the social security number. It is name, date of birth, address, phone number, sex, and
Phone number, name,
and sex. I think those were the main ones. Yeah. And then of course, the more information we have, the greater chance for a match within that system. But social security numbers aren't used.
and if they don't put enough information in, it's not going to populate somebody. So you have to have enough information so you can make sure that it's the right person and not somebody with a similar name or something like that.
Yeah. So we do have those minimum required, but the more information we have, the better.
Okay, well, let's keep going. See, lots of important questions for sure on this.
Thank you, Ken, and Crystal. So, 49% of all special needs shelters, they're open for Hurricane Idalia. were able to send the encounter alerts to the EMS system and contact notification services system. And 68 individual healthcare providers have and received data from EMS using high-speed data. Publics executed the Shooting addendum to share their data with the ePlus platform. That means that the platform has now even more data and richer data for the users. Home care now, home health agency reached out for access to ePlus. And as Pam had mentioned, that we continue to do outreach and education, and because of that, more and more organizations and counties are actually getting access and joining to ePlus. Currently, 57 organizations across 38 counties have access to ePlus.
Can you remind us what CEMP is?
Comprehensive emergency management.
Comprehensive Emergency Management Plan, thank you. Is that right?
Is that right? Because I have no
I
idea.
believe that's it.
We're hoping that's it then. All right. No, that's right. Thank you. Any questions on that one? Okay.
So the last item I want to discuss on ePlus is the missing person application. The vendor has made a lot of enhancements and all enhancements were completed in July. So now it has more capability and it is more user friendly. So for the missing persons, when they found, the platform not only does provide just the location information, it also provides the ability to create various reports on missing persons. It provides the specific encounter type, admit or discharge, and where they were discharged. And if they expired at a connected facility, then that report will also be included. That information will also be included as a death indicator in the report. Previously, a missing person had the additional ability to upload panel. So what happened that when you upload a new panel, it used to overwrite the old panel. But now it is possible for the user just to add the new missing person to add to the panel. So they added that new capability.
Can I ask a question? I don't understand that. Yeah. So are you saying, that's not clear to me, so if someone can explain that a little, because it almost sounds like, excuse me, I added a missing person application. But then if I added a second missing person application, it overwrote the first one. So that means you would never have more than one. So that makes no sense to me.
So you can upload a list of missing people. So like, just kind of like a patient panel for EMS. So if you have a list of individuals like CASER, the kidney care emergency response team would have a list of individuals that they are looking for that are on dialysis treatment. It would upload those individuals. Previously, you would have to, if you had one additional person you wanted to add, you would have to upload the entire list with that one additional one person. Now, you can just add that one additional person and it doesn't take away any of the prior individuals.
So is that based on user? So in other words, I'm a user that's
Yes.
utilizing this versus the applications?
Yeah,
Okay.
it is a user that is uploading data to try and find out if these individuals are being seen at a healthcare facility or have been admitted to a healthcare facility. So if you have 10 patients and that you're looking for, 5 of them are at an admit facility, 3 of them are at an Orlando health facility, 3 of them haven't been found yet, right?
Yeah.
So those 3 individuals you're still looking for, and then maybe they show up at an admit facility a day later, right?
Right. So maybe you could reword that a little bit more to say your missing persons can be, or at least a user, because to me it sounds like it's a user. So I'm the user, I'm adding a list of missing persons, and then I'm going to go in and edit. I might take somebody off because I found them, and I might add somebody because I found somebody else I'm still looking for.
Gotcha.
Okay, that's what I think you're telling me is the functionality now.
Yes.
versus wiping it out because now I made a modification. So really, it's at a user level. So that wasn't very clear to me. That
It's editorial capability instead of
by user.
replacement.
Next slide, please. So now some updates on encounter notification services at the end of August. Right now we have 802 data centers and with 551 data centers tied to a data subscriptions, means they are receiving data back. We also have 245 data subscribers. There are over 30 million lives covered and unique lives are about 15 million. And on an average, every month, 9 million notifications are being sent out to the subscribers. We continue to see an increase in the number of participants. However, because we are going to transition, we are anticipating a period of latency over the next 2 quarters.
So can you explain? Sorry. Figure out we have lots of questions. So can you explain when you say we continue to see an increase in the number of participants? So when you say participants, how are you defining that? Is that data centers? Is that data subscribers? Is that data recipient agreements? What is that?
Yes, I'm happy to check that. So that's basically who are receiving the data and who are also sharing the data, all data subscribers and also data sources. That includes basically every.
Right now, it seems like mostly hospitals are the majority of the data centers for ADTs.
Yes, that's correct.
So when you're saying an increase in number of participants, that's not additional really data sources, it's more people that are subscribing to receive that data, or can you explain a little more on that?
We are expanding the data sources, so although hospitals have, that has been the primary data source for us previously. We're seeing more skilled nursing facilities, behavioral health facilities, urgent care facilities that are starting to share data with us.
Okay, we haven't seen that very much volume, so that would be interesting to see the numbers.
Okay, we can put that down as an action item.
Because we're all looking for nursing home long-term care numbers, and that's where we see there's a huge gap.
So I just want to add, when Pam has just mentioned, when we saying that we are seeing an increase, that means month to month increase, even quarter to quarter increase. These numbers are going up.
Numbers are going up and accessing the data,
The participants who are sharing data, that more and more we are having more and more data sources over the quarters.
Yeah, we'll get you the numbers for the next meeting. We'll have numbers on data sources and the types of sources. The types of sources along with subscribers.
Yeah.
We'll have those numbers for you.
Thank you.
So that was my last slide. Any other questions?
Anybody online? Question?
No question online.
All right, well, thank you. Great. So who is going to be giving us the update then on the website?
I'll be taking
James
it
doing
on.
that? Okay,
Yes, I'm gonna
thanks.
try to share my screen. Give me 1 second.
I gotta stop sharing, hold on.
So Jamie, should I do a caveat that this is intended to be a quick update and not a design session for the group?
Yes, and I was about to say the same
That's hard.
thing.
Yeah, hard with you there virtually.
Jamie,
Is that a thing that some of the DOH people are at? I don't.
Jamie, did you hit the share?
Yeah, I think I'm sharing now. Does it look
Live.
like, can you guys see my screen?
No, not yet.
Okay, let me try that again.
Do you have to allow them to share?
How's that?
Not yet.
Just make yours bigger. Well,
I can see it. I could see it on the screen.
Just the people online.
So not in the room, the people online can.
I'm gonna stop sharing and share again. Give me once. You have it?
We don't in the room. but-
Let me stop sharing and I'll share again. See if it's maybe getting hung up here.
Why is your picture not showing on, you shared it?
Aaron, do you know where are those guys? Jamie? Not in Tallahassee.
Let me take control real quick, see if it'll. Requesting control, Crystal.
You stop sharing.
So while they're trying to do that, in the room, we got a handout for the next topic, which is the HIV vendor transition. And
There we go.
initially that
There we
second
go.
page was missing, so you might want to peek. But they got it, see, as soon as I said that. All right. There we go. Can
Okay,
can
thank
the
you.
folks online still see it?
Can somebody tell us if you're on?
Yep.
Yes, we can see it.
Yes. I just
Okay,
texted.
great. I have this also pulled up on a mobile phone so that I can show both sides, but we'll see how it goes. If it's moving slow or anything like that, then we may forego that piece. But currently, yes, this is not meant to be a design session on the fly, but we do want some feedback on some major points. Ultimately, we will be following up once we get the next phase of the contract underway. What we're looking at right now is looking for, with our vendor, probably about a 2-month turnaround on sprints. So we'll essentially be designing in the next phase for 1 month, testing for 2 weeks, then going live and retesting for 2 weeks before we go on to the next sprint. So this is the current Florida Health Finder website. I will share that we did go live with the current mockup. The team was vigorously testing for about 2 to 3 weeks, doing some user acceptance testing in-house under the test environment. But some of the elements, because of all of the data sets that plug into Florida Health Finder, and all of the movement within the framework and the architecture of that data, we needed to test it live because there were a lot of links that weren't completely moving where they needed to. So under live, we did do a lot of cleanup. While it was live, we did take advantage of getting some feedback from all of our statewide surveyors. So we hosted a week's worth of, I think we did 3 or 4 days worth of lunch and learn sessions. Essentially, we did a 30-minute invite only to those folks to get their feedback. They were walked through where data used to be, and we wanted to hear from them. Where do you go to access what's most important to you? A lot of them, as they're in the field, they rely on their phone. So we wanted to definitely have like a mobile friendly version of the new website that they could pull up and get familiar where things were. I think overall, most of our feedback was very positive. There were some key pieces that we didn't know we needed, so we pulled it back right as Hurricane Idalia was on its way. Part of that was we didn't want to take the risk of trying to train new people while they're in disaster prep and recovery mode to try to find information that's vital during that time. So we pulled it back, we'll call this the classic look back up. But a lot of their feedback that we had, we're currently working on implementing. We are also simultaneously starting to ramp up an outreach campaign. So we have a marketing vendor. We have multiple videos. I think we have about 15 different video ads. We have a lot of photo B-roll shoot that we'll be putting out some promotional material. Right now, we're going to coordinate with both vendors so that when we are ready to go live, we can put out all the marketing and make sure that we can handle all the traffic that we're going to be getting. As well as in-house, we are standing up another campaign to do weekly ongoing webinars and information sessions for consumers, because right now we are hitting our internal customers, which are ACA staff. And if anybody in the room from any advisory council members would like to have one of these sessions with your constituents or anyone that you're representing, we can certainly schedule some of those. We would love to have some feedback in those sessions. That would be a little bit deeper. There we won't mind one bit. But essentially, I'm going to flip back and forth between the screens to show you what we currently have out there and then what it's looking like. I think I see some questions primed, but go right ahead.
Yeah, Jamie, hang on one second. So who do we contact if we want to have a session with our constituents? But I think it would be good if we had an advisory council session, if that would be possible. And I don't know what your timing is on that, but Diane,
Yeah.
maybe ask some questions.
Well, Jamie, I had no idea you were putting it up for a test, but I found out about it because I heard a lot of grief about it. And so I was like, I can't help you there. Because they could not, they were missing the old system. So they were very happy when they saw it go down, the old system come back up. So it would have only been helpful if we had known that was going to happen.
Yes, yes. No, we heard a lot of loud voices that definitely spoke back to us. We were working with our vendor around the clock to try to address as much as we could on the fly. We were making progress in adding a lot of the tools, but we do need the opportunity to walk folks through where things are. Things do move. If I were to be asked to go look for, let's just say, some security services for cybersecurity, more than likely I'm going to go find a vendor. I'm going to have to look around a little bit. I think a lot of it is folks also have saved links to certain areas that have moved. And so the walkthrough sessions really did give us a lot of positive feedback. And we are going to be ramping that up in-house as well. We do have a staff member that will be doing those weekly. I think in the past, you guys may remember Jess Hand used to do those. We'll be doing a video series. We also have a tutorial instructional video that is being currently recorded that will be on the homepage, as well as some updating some FAQs. So we heard everybody loud and clear. Truthfully, we're trying to get as much of it done before we put promotion behind it because a lot of the linkage was needed to be tested in live. We're in a good spot now. But yeah, we would welcome an opportunity maybe at the next session if we want to go ahead and take a deeper dive. We can work it into the next phase of the work. At that point, I think it may line up and we can have more progress between now and then also to share.
So Jamie, timing wise then, with the new look is coming soon, what's your target date to get it up?
So as of right now, given our current agreement with the marketing vendor, we're thinking sometime in October. That it
So
could
if
be
we
far
have a
along enough.
session with you in December, that's after the fact. Is there anything that,
We will be updating it. We will be updating it as it's live though in the phase 2 part. This is still part of the phase 1 work and of the phase 1 agreement that we have in place. And we want to get this out and done before that agreement ends. Now, if there's interest in doing an ad hoc session and folks are able to, but I do think that I believe if that opportunity even does come up, the transitioning conversation, I think would probably be stealing some of the time and commitment from folks. But we could at least try to carve out some of the lunch and learns with folks outside of this. You guys can participate there as well. If there's interest in that, I think if you guys want to send us an email, if you want to go and send it to me, we'll get it to the team and we can start scheduling some of those.
okay, so just to make sure I'm following, if members of the advisory council want to piggyback on your already scheduled lunch and learn webinars, we email you, Jamie?
Yes, email me directly. We'll coordinate those, and once we have those scheduled, we'll send the invites out.
Is it possible for you to just send an invite out to all of us, and if we can participate, because you
Yes.
might have multiple ones?
Yes, we could do that. Certainly. When we have the next one scheduled, we'll do that. We'll take that as an action item for us.
Okay, so you're gonna just add us to the calendar invitations and you can
Yes.
accept them if you
Yeah.
do it, and if not, maybe you'll get the
Yeah,
next
we'll
one.
definitely do that.
Okay.
Certainly.
All right, thanks. All right, I know you wanted
No
to
problem.
show some.
So,
site.
this is the familiar classic look. I think folks know that we've got a lot of these accordion style menus, and the new website, the new look and feel is essentially looking like our healthcare transparency website. We did replace all those accordion drop down menus with this mega menu section, and we broke it out more categorically. So if somebody's looking for agency information, maybe they want to look at inspection reports or final orders, they can click here. If they're looking for public records, they can click here. If there's something of interest on the customer service side, probably the most one used is filing a complaint. They would click here and go there. Here's some facility resource links as well. The Healthcare education, we do have our consumer guides posted. So you can go there and collectively they're in one spot. Sorry,
Jamie, could you slow down just a little bit?
yes.
Yeah, thanks.
So this is the consumer report page. We collectively brought them into one spot. We are also adding on some additional education links. Those are coming soon. The external resources page also links to some of our other partner websites that we may have. I did want to go back because I think the loudest voice that we heard was that everybody in the field really used this compare link. This dropdown is an all-inclusive by provider type. You click it and you would get a result of all those providers in the state. And then you can further filter and look for what you're looking at. Our field staff definitely use that. I would say that would be the #1 button they used. We did not have that initially in the plans, but we did add that here. So now we have a compare quick links, and here you can go and let's say I was looking for hospitals. I can click hospitals and it would load the full-on list of all the state hospitals. If I wanted to filter down a little further, this essentially is a filtering tool. So if I knew I was going to, let's just say Highlands County, and I click that, it will then limit my results down to just Highlands County. If I had a name, let's say trying to think of a
Hey,
name.
Jamie?
Yes.
On that Highlands County one, was
Mhm.
that supposed to list all the hospitals in Highlands County?
It's the ones in their name. If I wanted to do, like, let's say I
Oh,
wanted
if
to do
it's in
Highlands
the
County.
name of the
Right,
hospital.
right. Now, if I wanted to do,
It's not my name.
But he said county, so that's why I was a little confused.
if I did Highlands County over here, it will pull all the ones in the county down. I'm from Sebring originally and couldn't remember how many hospitals. I haven't been back home in a long time. I always knew there was at least one in Sebring and one in Lake Placid. But if let's say I did a different provider type, so let's say I was looking for an assisted living facility. If I happen to not know the name fully where they are, but maybe I caught an ad or audio about it. Now this is going to take a little while to load. It's a longer list. I just want to remind folks there's over 45,000 data sets coming into this. If it is something that takes a while to load, what our vendor is doing is they're looking at the ability to load the first 1,000 results while the rest of the results load on the back end. That way folks can actually see and start looking through some of that data rather than waiting or timing out, depending on their connectivity. This one is still loading. We'll give it a minute. If not, I'll go to a different provider type. And that is one function they're still working on. We do want to build it without the ability for it to break. So I'm just going to hit wait and just let this load. This is our largest one. Another big piece that folks wanted was the select all option. We do have that on the current website. So while that loads, let me just go back to show you where that's at. So if I were to go to locate a facility and I wanted to locate by type, and I don't know what type, I may just have a name. Even if I hit select all types here, it does ask you to limit your results down a little bit further. So you get this little pop-up because it doesn't pull in full-on data for every single record that we do have. You still have to find a little bit further. If you want to further define it there, you can. If you wanted to go down to, let's just say Orlando, and that's as much info as I have, I can then hit the search and it should be able to pull up all the providers from that, from Orlando. So in the same way it does work on our new page. So it looks like the results have loaded. So if I just knew that, let's say the name Happy, and I'm hoping there's the name Happy in one of these.
Good luck with that. There were so many. There were a lot of happy places.
Hey, we're projecting, okay? So Happy's there, and I can see there's 5 facilities. If I did know a city, I'm not gonna go that far because I may pick the wrong city, but let's just leave it at Happy. And if I do want to pick one of these, I got it down to 5. Let's say it was an ALF, Happy Family ALF. I'll click on that one. And just like before, if you wanted to get to the provider profile page, you would click on that result. And so in the old website, let me just pick one just to show you the provider profile page. We didn't change much here. We left all the information that was there. We made it a little bit more concise and broke up the sections a little bit easier with just some borders. There's a little bit of drop down if you want some additional information that is being provided. But why we did that also is it looks better on the phone view and it's a little bit easier to see. All these links still link to everything that was there before, inspection reports, details. If there are any sort of fines and they have anything, they'll be listed down here as well. I know one of the action items was to see if we can move some of this information up, and that's something we're going to look at in phase 2. But the new website does have that. If I wanted to just search a different way, you could click the compare and locate piece. This essentially is going to pull in all my provider types. I'll just go to hospitals because they're a little bit easier and there's not as many of them. And now I can choose different categories. So if I wanted to look at compare summary or the compare HCA HPS measures or the HAI, the quality report card, I can click here. If I'm just trying to find some hospitals in my county, I can go to locate, search by facility. I can choose my county from the map. I could also choose from the drop down. We heard that oftentimes folks may want to find hospitals or facilities in more than one region. And so what we did is we started to add the capability to select more than one county or more than one region so that folks can not be limited to just a county. I'll just go to Duval, hit search, and this will bring me up. Bear in mind, this does have a proximity search piece. So if you wanted to search within your county, you could put in your zip code, and it would also just bring out the results based on that zip code and the area that you select. So I just chose Jacksonville. SAM info's here. Provider profile page, you click on it, it will take you there. I'm going to try to click over to the phone version because I think the phone version was very well received by folks. They could look at their data tables a little bit easier. Give me 1 second to see if that'll let me click over to that. Let me know if it changes screen.
Doing that, Diane, did you have a question about the profile page?
Well, he showed an ALF, so I was just wondering what about the hospital, and he said we were asking to move things up, and that you guys were still looking into that, so I guess it's.
Yeah, and I wanted to add on to that because I caught that also. So we have, whether it was the last meeting and the meeting before that, provided different suggestions. So it would be good for us to know which of those are in phase 2 so that we're not asking you the same questions again. So that would be helpful, I think, to the group. And also, Jamie, what's the timing then? If you're going live in October, when do you think that next batch of suggestions would be able to be incorporated and go live?
The next batch will be around December, and right now the plan is October, but I won't say that we're 100% there yet. We still have to vet some of these updates to leadership and make sure that what we have is also enough for our field staff. Next week I'll be demoing where we are now since the first go live test to internal leadership and getting their feedback. So right now we're planned to be around October, and then the next phase would start around December as far as what we will be pushing live.
So Jamie, maybe you and I can go through my notes from the previous meetings and what we've captured in the minutes, and that way, we can have kind of a status for the December meeting.
I actually have an action item to do a chart.
You do have.
Or
yes, I'd like that. That'd be good.
Okay, so all right, so Pam has already created a chart. Not sure if everybody could hear that, so we'll share that. Is that something that could get shared with us before the December meeting if we're going to be looking at attending some of these lunch and learns?
Yeah, I just need to update it with what has been implemented and we're in which phase it will, if it has not been.
Okay.
So let me update that. It may be a couple weeks before I can get
Okay.
that again.
All right, well, that would be helpful, to kind of have that off to the side while we're, participating in the lunch and learn.
Okay.
All right, any other questions at this point? Thanks.
So I wasn't able to load the phone. I've some limited, I think, internet connectivity here, but I'm using my phone as my hotspot as well, so that may be why. But I did want to show, I think you can see my screen back. I'm back on the computer view. The next section, so immediately you're going to see linking to all of our other websites. We have the healthcare price bundle page here. My Florida X is here. The Cancer One page is also there on the end. But as you move down the page, what we did is in the old website, or the classic look website, I keep calling it old. If you wanted to find some of the dashboard data,
There you go.
if you wanted to look for some of the dashboard data, you often have to look through the right category here in the drop-down menus. Let's say Gold Seal nursing homes. That's one that I know folks are kind of going into often. You still had to look for it. And so what we did is we essentially gave them their own spot on the homepage of the new website. So now if you wanted to do Gold Seal, hang on, I'm sorry, let me scroll back down here. That would be down here. And so for these dashboards, if there are some dashboards that folks access very frequently, we can continue adding them. We can load more on here. If there are some that we're seeing that aren't used that often, we can swap them out and take them down. But this at least allows somebody to find it and click on it one time and get right to the report that they're looking for. The card section, these are other resources and tools that Florida Health Finder has posted on there. If you click on a card, it'll flip over, and on the phone version, you click on it, it also will flip over, and then you can click your link of what it is you're looking for. We do have a card for Price Finder. We also have one for the Florida Insights web tool that is still being developed, and then once we get that further along, it would have a house here to link to that. Health IT initiatives are listed here. The patient safety culture survey, as that gets going and starts collecting data and folks start reporting on that, we'll have some information here and expand on the options. My Florida RX also has links to their different resources on their website. And these cards are changeable. So if we find that there is a big need for a specific section where folks are needing to go to, let us know. I will share, we don't have a lot of footprint sometimes. So if we expanded this to 8, then it does impact the mobile view. We found that 6 was the most efficient, where it doesn't seem to be too long or lengthy and things don't get offline. So we will try to make the best use of the real estate that we do have. At the very bottom, this is currently a placeholder of images. We do have a lot of actual content we shot that we'll be replacing here. One of these tiles will be our first walkthrough video. And the video is essentially an instructional video showing folks how to navigate the web page. And then we also have one that will be developed that's going to show folks how to pull data reports out. We're trying to limit it down to like 60 seconds or less, make them digestible, just the key pieces. But again, as we step up our ability to do these webinars, we're also going to be adding a button here where folks can click on to register if they would like to participate on a webinar. I believe our classic look page has that down here. So we'll be standing that back up and doing that in-house. I think in the past we were probably doing them weekly or every couple weeks. We'll be doing something similar, especially early on, for consumers to be able to learn about the website.
Jamie, just on that last one.
Yes.
Would you consider a link that is, 24/7 to maybe take them to a, YouTube video so that?
Oh, yes, absolutely, yes. We do have some videos that are on YouTube that are, talking about the classic look webpage that are outdated. And so as we create new content, new videos, we will be putting them up on YouTube and linking to that as well.
Yeah, that makes sense. Thank you.
Yeah, absolutely. I'll pause there and see if there are any questions. I think we're backing into the next section, but again, feel free to send me emails directly. We will, as an action item I took back, that we will be emailing all the members as we schedule the next sections for them to participate. Feel free to invite anybody who you would like on your side. And through that, we'll be sourcing some feedback. The only thing we ask is for anyone who's giving us updates and feedback of things they would like, that they are made available when we do begin testing that. We want to make sure it's working properly. We're not always the experts on how these things are used, but we want to make the best use out of this, out of the funding that we have and of other changes that we're doing. So we would just ask that they commit to also come back when we do start testing those, either in our test environment or in the go live.
One more question, Jamie.
Yes.
So I'm just looking at the ACA homepage. It is indeed the only way to get to this Health Finder, clicking on the link that says find a facility on the ACA homepage.
Currently, let me go to that page, and there are some changes we are going to be making on that homepage. So we do have to update some links on the ACA homepage. If you were to search for Florida Health Finder or Healthcare Transparency, this would essentially be your landing spot. We are going to change the name because this is the link to Florida Health Finder. You know, currently this will take you to the classic look. We're going to change the word quality here to say Health Finder. We're going to change this to say My Florida RX, and also change this to say Price Finder because there is a little bit of confusion. We also want to update the tiles to be consistent throughout. Because quality, I mean, essentially quality is a tool that we have. It's also a category of information that folks get. I believe that was some of the feedback we got on the last advisory council meeting is that these are a little hard to figure out what things are. But on our ACA webpage, we went through changing links to the new look. And then when we roll things back, we did have to do a lot of reassigning of that. But we will be doing a banner on the ACA homepage that'll draw attention to the website. We're trying to coordinate all that, keep in mind with all of our marketing that is being finalized right now. We want to make sure to take advantage of once that goes out, we can absorb it. We do have a live page that can be best used for all of the attention that it's going to get.
Just one comment on that, and I know we don't want to do design right now, is just if you would just consider in the back of your mind, the fact that it's using all the buzzwords that we in this room, and certainly you are the most acquainted with, but someone just looking for this information, a consumer especially, is not going to know to go to something called Health Finder. It's just not something that they would be familiar with. So I don't know what the answer is, but I do know we use a lot of lingo, and that can be very confusing.
Mm-hmm. Yes, we are taking that into consideration. A lot of the in-house, I'll call it the in-house outreach that ACA is going to be doing, will be more focused on the consumer. We want to hold their hands through it. We did learn that as we were walking through our ACA staff with the updates, they were essentially holding our hands through it because we were learning for the first time what their needs were. So we think for the consumer side, we will open it back up. We will do more hand holding on our end. Anything that they may need, we'll be doing whatever we can with our in-house resources to make sure that they understand and know where this information is at and make it more user-friendly for them.
Thank you.
Thank you. Any other questions?
Questions online.
No questions online. Okay. All right, so the next item is the HIE vendor transition, and you did get some materials, but I don't know why the second page didn't make it through in the original, so perhaps you got a chance to see it when it was sent out this morning. But this is not an action item. This is a discussion. And is it Pam who's going to take us through then? All right, thanks.
You getting us back on?
Yeah, I'm good.
Sorry.
Okay.
Oh, actually, for the folks who are online, who are members, they would have gotten the email. What about the people who are attending? Is that going to be posted on?
We'll get
on the website.
yeah, we'll get the rest of
All right,
it.
so it'll be-
We'll get page 2. on the
Right, it
website
gets swapped
after the
out. It's not
meeting.
yet, but
Yeah.
you'll get that. Okay, thank you.
Okay. And I'm not sure what slide we're on, Crystal. There we are. You can go to the second slide, that's fine. Okay, and can people see us online?
Can you minimize Jamie?
I just, we like seeing that
Where
little
the
box,
Jamie?
right?
Jamie's blocking our view. Just as a reminder to folks, and maybe folks that are joining this meeting for the first time, a little bit of history about the Florida Health Information Exchange. We initially, actually, I should have corrected this date. We actually began the project in 2010 and really began implementing HIE solutions in 2011 with Harris Corporation.
Patient hookup.
For the patient hookup.
all too well.
Yeah, way back when, working with Harris Corporation to deploy Florida Health Information Exchange services, and through funding we received from the Office of the National Coordinator for Health Information Technology. Our funding agreement with them ended in 2013. And we moved forward with basically a fee-for-service model where individual subscribers to HIE services supported the HIE here in Florida. So there was not any funding other than some Medicaid dollars to support Medicaid providers and continuing operation of HIE services. The contract with Here's Corporation expired in 2017, and at that time, we transitioned to utilizing Audacious Inquiry. Audacious Inquiry had been a subcontractor with Here's Corporation from the initiation of our HIE venture. And so at that time, we transitioned and used Audacious Inquiry. We were really focused on the account notification service at that time, as many of the providers here in Florida that were connecting to our state hub for sharing patient record data were also connected to the national networks. And so a decision was made to, hey, let's get everybody to connect through those national networks for those patient records exchange. And that is going very well. And we need to remember to bring numbers on that next time we're here too. So now we are at another transition for vendors. You will recall that in our meetings, the end of last year, beginning of this year, we had shared information about Audacious Inquiry being acquired by Point Click Care. And so that occurred at the beginning of 2022. And so the new vendor, you can go ahead to the next slide, the new vendor would like to offer or expand the services provided to Florida subscribers of the Florida HIE, the counter notification service. So there are a lot of benefits that can occur with some of the changes they're recommending. You'll recall in our conversation, we discussed the addendum to the ENS agreement, which allows for data retention and sharing across state lines of data. The data retention is key to being able to offer the additional services that they would like to provide to Florida providers here in the state of Florida. I think that we've discussed, and we can share some more about the solutions that they want to provide. I think they shared some of those solutions, the ability for emergency departments to get data on patient history at other healthcare facilities, communication between hospitals and skilled nursing facilities, and a lot of other information.
So I just want to step back here. When you say sharing clinical information, right now it's just an ABT.
Yeah, right.
So are you talking about expanding outside of an ABT to a CCD, some type of clinical information?
So some of the solutions allow for a kind of the Archer solution that we offer here in Florida that can tie a CCD to a notification, alert notification. So that if you subscribe to a particular service, you can get, here's a notification your patient was seen, and here is the medical record tied to that at the healthcare facility they were at. So primary care provider could get the notification and the record from that visit.
So we're capable of getting clinical data today and through the national exchange and through larger systems exchanges. So I'm not sure when you're saying an ABT, so I get an ABT that I've been admitted to Orlando Health. In order for Point Click Care to send my CCD, my clinical data, I have to share that with them. And it has to be stored somewhere. I mean, because this is.
It would be through the national exchange.
Okay, so I'm not that's already happening today, right? So this is not new functionality.
You would receive it in the portal, where you would get the notification for the encounter notification. You would also have that record with it. So you wouldn't have to get, here's my notification, I'm gonna go search the eHealth Exchange to get the CCD. It would come together.
Assuming it doesn't already come down through your workflow.
Right.
In your EHR.
Right,
So.
right. There's different solutions and you wouldn't need both of them. So, there are varying solutions. They have multiple solutions, but, but there are some considerations that we want to get, some input we want to get from the advisory council. There's lots of different solutions that they're offering, just that encounter notification data, all the way up to encounter notification data plus CCD with that. We already offer that solution to some providers as Archer here in the state of Florida. So I know there's a couple of provider groups that already have a similar solution that they already utilize. It really just pulls the data together so that you're not having to go back out if it's not, because it wasn't in their workflow, right, to get that data. So it varies between on the need of the organization. Remember where I was. Okay, so the modifications that they are looking for would require us to look at our current structure, and there would need to be a change to our current structure for the Florida HIE Encounter Notification Service. And although the changes would allow for larger connectivity across state lines within the point-click care network, and the ability to provide historical data, they would require changes to our infrastructure and policy. So let me go to the next slide.
Can you back up for 1 second?
Yeah.
So just to be clear.
Thank you. So can you, one more.
Well, back up.
Yeah, the current versus the new.
Mhm.
So what you're saying is the proposed options here under point click here do require some policy decisions.
They would require changes to policy and infrastructure changes.
And in terms of the timeline for their capacity, so if those barriers were overcome, is how quickly could some of these additional features be incorporated?
They could be, well, depending on where we go, as early as next year, I would think.
Okay, so part 2 data exchange, that substance use disorder, right?
Right.
Okay, thank you.
Can I just ask a question on your grid today, post-acute encounter notifications? We're not really getting it from the long-term care.
Right, we only have 30% of the skilled nursing facilities right now.
Which are on point click care, majority of them.
Some of them are, a majority of the skilled nursing homes in Florida use point-click care. One of the things that has been articulated to us is if we do move to this, they don't, the current vendor does not want to confuse skilled nursing facilities by connecting them to our current counter notification service when they can connect to the point-click care platform. And if we move over to their platform, then we would have that connectivity.
Interesting.
So just we need to.
So to just that kind of raised an issue in my mind, which is this going to be a choice at the end user at the facility level as to whether they would like to subscribe to those services, or is this pushed down from us if we do adopt it?
So the base service that they would be offering would be the encounter notification service. However, the sharing of data, in order for them to provide these other services, those our endpoints would need to move to that national platform. So that is, that's part of the discussion that I wanted to get input on from the advisory council. The agency wants to get that input from you guys as to how we move forward. Just as something I forgot to mention, just so you guys know, our current contract with Audacious Inquiry does expire in September of 2024. So that's another consideration that the council needs to be aware of as well. I'm gonna go ahead and move forward and, just go ahead and keep asking your questions. Go ahead and go to the next slide for me, Crystal.
Question, I'm sorry, so the end of the contract means you have to reprocure?
Yes.
Is that what that means?
Right.
Because they are required.
Yes.
So that, I was gonna answer that too, because I had this underlined on your first page of the document.
Yes.
Which is, what does that September, a year from now, does that trigger just starting from scratch and then they could come in and say, we're the existing and we can add these services to it? Or are we mandated to stay with them in any regard?
We are not mandated to stay with them in any regard. We are mandated to reprocure. So we will be working on that. We'll be doing a procurement. We're working on deciding if we want to do an invitation to negotiate or a request for proposal. And so, we'll be working on that with our procurement office over this next year. We're starting that now. And however, Point Click Care can submit a proposal and we could move forward with them. But we, want to get input from the advisory council as well on some of the things that we need to consider as we look at where we're going and what we want to do. But other vendors could also, of course, submit proposals. That would require us to transition folks from the current solution to a new vendor. We, of course, Point Click Care is asking us to transition folks from our current solution, the current infrastructure, to the new their national platform. So,
and then the other thing that wasn't on either page is really just a consideration of the finances behind this. And I didn't know if you were going to discuss that or if that was something that's purview of this committee or how that, because obviously anytime you're doing an RFP, you're going out is going to be a factor.
we currently have a no cost agreement with Audacious Inquiry, and we would go out for another no cost contract.
That's no cost to the agency.
No cost to the agency.
Not to the providers.
Yeah, just to clarify that, right, no cost to the agency.
So there are definitely considerations there. Yeah. Thank you, Diane. In addition to the benefits that moving to this national platform brings, there are also other considerations, of course. The requirement for data centers to agree to allow for the retention of data, of patient data, right? And when this was initially presented to us, it was presented to us as a voluntary addendum. And as we have had conversations with the vendor, it's become apparent that really there would be a definite need for facilities to allow for that retention of data. So that's something that,
So just to follow up on that, retention of data is definitely a concern for participants. And for how long, and identification if there's a breach, as well as commercialization of that data, and our ability to restrict that data being utilized for a commercialization purpose, that we would not be.
right, and that is all part of the agreement, and in that the addendum, that the DUR addendum, I think all of those things were addressed. So facilities can have their data, ask for their data to be cleared every year. So we would only have a year's worth of data for facilities. So That was one of the things we addressed in the addendum. Another thing that we addressed in the addendum was that they could not, it cannot be used for commercial purposes. That's a definite. And also the security requirements that they be high, I mean, they are required to be high trust accredited, the vendor, and there is language around breach and that sort of thing within the current ENS agreement.
And my understanding is this addendum is going to be reviewed at the legal work group on October 10th.
Yes, the addendum and any other changes that would need, one of my issues is we have it as an addendum, as a voluntary addendum to sign. And so one of the things that we want to do is, do we want to just include the language in the ENS agreement if it is going to be required, right? So that's one of the things that we need to consider. My understanding from the vendor is there is not a solution that allows for folks to share data that is not retained.
So we have to be careful and cautious to not reduce the functionality of the ENS system today and the benefit that it serves to the providers that are utilizing it today by forcing a provider to allow them to retain their data if that provider has some concerns with that. If you're putting it in, it's not an option. It's not a choice. It's in part of the participation agreement. And so that also impacts their potential. If that provider gets lip funding, that impacts their lip funding because now we're forcing them to participate and allow the data to be retained when they don't get their lip funding. So I think as an agency, especially as an advisory council, I am not comfortable in saying, enforcing a facility or provider to go against what their organization's desires are. And if they do, if they go with what they believe is right, then they lose funding potentially. And if they need the funding, then they have to go against how their position is on data retention. So I just want to be cautious on that and make sure that everybody thinks that through. And that might be something in the legal work group to look at as well. Because, and obviously I can't speak for every health system in the state of Florida. And I would not try to. I'm not even speaking for my own at the moment because we're still looking at the agreements and looking at what we feel comfortable with or not. But I just want to make sure as an advisory council, we are very cautious and intentional about any thoughts we may have or recommendations.
So what I think I hear, Diana, I just want to make sure is that the allowing that to continue to be an addendum to the ENS agreement, so that there is a choice by provider, so it does not impact their the lip funding is where we're at. The issue that I'm hearing from Point Click Care is that they are not going to have a solution that allows for them to receive that one-time data. And so that's something that we can look at in maybe our new procurement, that we do ask for something that allows for that.
Yeah, and I'm not sure I understand, since the contract and the process that we have in place today is ongoing for another year. So if Point Click Care acquired AI and now they're running that system today for us, what prohibits them from continuing it after the contract?
So right now they're operating two systems, and so technically they want to, which costs additional money, and so they want to transition to one infrastructure. And so they're looking at moving data to that one infrastructure. So, that is really kind of the limitation there, is trying to transition folks to their new infrastructure for ongoing.
But not for between now and September.
They would like for transition to begin in January. And so, but that is why we're here to get input from the advisory council. Some of the things, as far as, we talked about data retention.
Yeah, Pam, can
Yeah.
I just ask a clarification question, because I got a little lost a few minutes ago.
Okay.
When you say national, are you referring to the vendor platform or the national HIE?
I'm referring to the vendor platform. The vendor has a footprint, greater in some areas and smaller in others, but they do have a footprint in all of the 50 states. Some of them may just be the skilled nursing facility connectivity. Some are with HIEs in those states, and some are not, or just use individual providers using that service.
Do you know if any other state has adopted the?
Use your mic, I'm not sure.
Is there any history of any other state having adopted what they're proposing for us to adopt?
So there are several other states that have, were using Audacious, had a contract with Audacious and Gray. Texas is one of those. Delaware is one, and so it's a little bit different because Florida is the largest utilizer of the encounter notification service. We have much more breadth, more providers utilizing the service and health plans utilizing the service than any other state. Texas is has done the data use retention addendum is what we call it, or the DUR addendum, the addendum that you guys looked at previously. And they are working with the hospitals that are sharing data with their encounter notification service to retain data. I think most of the hospitals, but I don't know the percentage of hospitals that are actually sharing data, but I can get that information. I think Delaware is similar, so we can get a percentage. I think I have a call with Texas coming up here in the not too distant future. So good. You can just leave it right there. To do this, so we would need policy modifications. So changes to the consent policy would be needed. I know, Molly, you brought up the substance use disorder data and sharing that. Some of the tools that are out there have the capability of allowing patient consent to follow patient information, which would allow for us to share substance use disorder. So that is a plus. There would need to be a change in consent. So there would need to be a consent to share versus the current consent to release data or receive data. So right now, data flows, it goes away. For somebody to have a patient on their patient panel, they need to receive patient consent. And so they get patient consent, they put the patient on their panel, and that's matched, and it goes to the provider. That does have a limitation for us in sharing substance use disorder data. If we can, getting the data and maintaining that data and retaining that data. So if we get the consent on the sharing side, that allows for that data to be shared. It will also allow the patient to, instead of going to each individual provider to remove their consent, they can remove their consent at the HIE and they can contact the Florida HIE and say, I no longer consent for my data to be shared, and that can be done at that level.
So the consideration, I should say, more than anything, is when you have an opt-in, obviously it's going to take time for all the systems to change their processes and consents and go through all of their legal reviews and just ensuring that they crossed all their T's and dot all their I's. So when you have an opt-in, there is always concerns about the risk of shining a spotlight on an area that a lot of consumers are very confused about. They hear about, oh, I don't want you sharing any of my information, even if they're not concerned about substance abuse or alcoholism or anything. As soon as you try to get a special consent to share information, they all shut down because they don't understand it. They don't want anything shared. So my concern with that would be, how many then do we lose because of the change in the process and now trying to request them to opt in? So there's just a lot of considerations when you're changing a process and a policy that has been working well for us, for the hospitals for years, and have had some benefit by. So that's another consideration.
Okay, and so there, HIPAA does allow for treatment, operation, and payment sharing of data. It's just the behavioral health data, right, that we've always struggled with here in Florida, because there is specific language in the law that says we have to get explicit consent.
Yeah,
And
which is why we have the process today we have that works out well. It's an opt-out more than an opt-in.
It's Florida law that requires consent for behavioral health, yes. So the other considerations for us to think about. I know I'm missing a lot of information because we were talking and I'm like, are we covering that or not? We talked about it being voluntary. And I just want to be sure that I'm clear when I talk about the model. So right now, Florida connects to Florida. You know, we share our encounter notification, and it is, and we have that infrastructure. And so the connection to the national model isn't the connection of Florida to the national. It would be each individual hospital connected to the national model infrastructure that Point Click Care has set up. But I just want to make, does that make sense?
Since we're not IT in this room, just being clear, are you saying basically each hospital's would be connected to Point Click Care's platform, and that's how they're, so how does all of this align with what's happening in the other national discussions and TEFCA and the other opportunities? I mean, I'm just trying to understand, how does this align and compete with the other?
So a lot of the, I mean, well, there's several considerations, right? So you have the CMS Medicare requirements to share ADT data. And then there are the TEFCA policies that revolve around sharing medical records. I think most facilities, most of the hospitals here in the state of Florida are connected to the national networks, one of them at least. So we have that data sharing, as well as a lot of providers here in Florida. We've got a good number of providers that are connected to those national networks that are sharing data. So, I mean, I don't think it aligns with, the new platform does align. It doesn't take away from any of those requirements. One of the things that we need to look at is, would there be any consideration of, would it be information blocking if they said, well, I don't want to allow my data to be retained to share with anybody? So those are things, because there are those information blocking provisions that are out there nationally. So, you know, we do need to take a look at that as well.
So we have not yet convened the legal work group to do anything in October 10th. Oh, it is October 10th.
Yes.
Oh, okay. All right. I wasn't sure if that was, what's on their agenda?
This.
This.
Okay.
This.
But it sounds like there's IT components too, though. So,
Well, we do have our Hayek meeting that will be meeting in November.
so Hayek will pick up the IT issues on this?
Yeah.
Okay.
Yes.
So usually, I mean, my understanding is this group kind of directs the Hayek and directs the legal work
Correct.
group. So can we just be very explicit about some of the things we want them to consider?
Yes, that's why we're here to.
Okay, no, I just wanted to make sure it was to those groups and not just us
Right.
kind of just talking, so that they can get some experts around the table.
Right, and that was gonna be my suggestions. I don't know if Hayek is the right group, but,
Yeah.
we really need 24 end users to say, pound their fists on the table and say, no, I use this every day, this is not gonna work, or hug and kiss and say, this is the best thing that ever happened, and we want.
Yeah, I'm not sure about the Hayek either.
Or
so-
somewhere in between.
There are users of this on the Hayek, so we've got DOH, who is a large user of the account notification service, as well as the health exchange. There's, Nemours is represented, there are a lot of users and IT folks that are on the Hayek, and that's why they're there, right, to give us input on the technical aspects of it as well.
So could I, ask that there be consideration to make sure that you have the IT from large health systems participate in this meeting? So somebody from Jackson Memorial, somebody from Daycare, somebody from Orlando Health, somebody from Advent Health, somebody from Baptist, somebody from HCA, just because it's the hospitals that are gonna be impacted by this. And so we need to make sure we hear.
They be
from
yes
them.
at the Hayek. So it's not necessarily, the Hayek as the
Right.
group. It's can we invite others to participate and be able to weigh in?
And I think it would be helpful even to prepare for that meeting, to maybe have sent out some very detailed, that would be above my point, questionnaire to all those people, all those stakeholders, so that there is some external input to consider, hopefully by as many people as we can get in the room who would, on a day-to-day basis be affected by this, because I feel like I only have a very remote state personally. But we have to have this work for the people that are going to either adopt it or not adopt it, and otherwise it's just an exercise in futility.
Okay, so what I'm hearing is you want us to get input from some of the larger health systems, and maybe even doing a questionnaire or a survey of current HIE users. So I've got that. Some of the other discussion items I had wanted us to, you guys to provide us feedback on is, what considerations should the agency be looking at is the benefits and the consequences of moving the data sources from the current system to the national system that maybe we haven't thought of. I think I heard Diane say cost was definitely a consideration, and for that move to the national, I believe that Point Click Care is willing to take those costs, so there wouldn't be that. But if we change to another vendor, there might be a cost.
Yeah, we want to keep it affordable for the providers so that we.
But is there a cost to participate as far as we're sending data, but to get data back? I mean, there's a lot of.
So, and another thing that's a great point, Diane, one of the things we're looking at right now, because of the services are being provided back are different. Our understanding from the vendor is that prices for the basic system that we have right now would remain the same, right? For those subscribing, there is there's some pricing for new services that would be more. There would be an increase to price. Just as a reminder that our pricing guideline is part of our ENS agreement, so that would be a change to our ENS agreement. So we are working with the vendor to try and get some clarity on the pricing infrastructure for what they're going to be offering for each of the services. We also, I believe there was a request that there be allowed to be a 5% increase annually. So we're looking at that as well. And and working with the vendor to see how we can maybe offset that, so. So pricing is definitely, something that that is a consideration. So, yeah.
No, I was just waiting to see what other considerations you had on there besides the cost.
I'm looking for those considerations from you guys. I'm
Data
waiting for you to tell me, what else should we be considering?
Data retention, we had mentioned.
Yeah, data retention,
Commercialization of the data,
Indemnification if there's a breach,
indemnification if there's a breach.
the length of time.
That's the
Yeah,
data
I think-
retention, but
Yeah, I mean, I think all of those are in the current ENS agreement. Some of those things are.
You said restrictions on commercial
I think,
use.
I think retaining data, is a bigger issue.
Right.
And where's the data stored and just any liability and identification for that.
That list not long enough for you?
Well, I mean, some of the commercialization, I think that is something that is already dealt with in the county notification agreement that would not be changed. We would not permit that. The data retention and storage, we can, that I think it would be held within the United States. All data would be held within the United States. So are there other, besides like where it's held, what are the other concerns about data retention, other than, breach?
So my question for you, on behalf of your staff and yourself, about this?
Well, the main thing is making sure that we're getting stakeholder input and that the solutions that are being brought to us meet the needs of the stakeholders in Florida, and that we're able to provide solutions that are beneficial to providers, right? So we want to make sure that we're able to provide those solutions. We also want to make sure that we're able to continue to support public health, because one of the things that we do with the encounter notification data is we do share that data with the Department of Health and surveillance programs, inpatient data with them. We do provide data and have a partnership with the emergency management department, medical services unit, so that we get ambulance data for individuals that are treat and release, we call them. So treated at home and not brought to a hospital. And then we also share data back on patients to improve quality of care by those emergency management personnel. We also have data going to the brain and spinal cord injury program, so that they can follow their patients within that program, and they can also get data on discharge codes that indicate an individual has had a severe brain or spinal cord injury, and they can follow the patient to get them services, as well as the potential for assisting other registries of the Department of Health, like the Cancer Registry and other.
But all of that's not through ENS, that's through all the different.
ENS is used to provide data to them, yes. But it's not all, no. Syndromic surveillance gets data directly from hospitals.
Right.
On,
And the DRGs are coming from probably some of the other data, because you're not getting that out of ENS, the APTs.
Right. It's just getting that basic data so that they can know when they can help people and what's going on with patients that they are trying to assist within those programs.
I do think if you get the right individuals in the room from the larger health systems, and just even from a smaller health system as well, the IT teams, if you will, they will be able to tell you what the benefits are of the ENS service today, what gaps there are, if there are any, of data that they'd like to get, and how might best to receive that data, versus what they're already utilizing through the eHealth exchange or through other electronic record transfers. So I just want to make sure that we bring those who know, the specialists, the experts in the room to have that conversation, because I don't want us to try and feel like we're helping providers and we end up actually doing the reverse.
Okay. And then, I do have that noted, and one of the things that we do know from entities that do receive the data, like Department of Health has shared with us, is there is a gap in some of the data we get. We do have that, this is the data that we need for data sources to send to us. And there are hospitals that are not sending all of that data set, or are sending it in a way that we can capture it in any kind of notification service. And having that retention of data will allow us to improve that.
So, I mean, and some of those challenges or gaps, if you will, it'd be helpful if that was brought to the discussion and forefront, because there might already be solutions. And if we're not aware, I wasn't even aware that the Department of Health was really utilizing the ADT, the ENS service very much. So I'd love to see those numbers, because even when we did the patient lookup, which is missing from your timeline, and I'm probably more sensitive. I'm probably more sensitive to that because we put a lot of resources and dollars behind that. I know you did. So, but the Department of Health never engaged in that because all their systems were different, and they never participated in the patient lookup where they could have gotten CCBs on all their patients. So that's where I'm very interested to, if somebody wants to come to the table and say, this is what we're missing, well tell me what you're using today. And I haven't seen.
And I'm just referring to the encounter notification data and data sets being missing from that, and even from our Medicaid quality office that gets that data for fee for service and from the health plans. There are segments of data that we're not getting from hospitals. Not that that can't be, we could, I'll shout, submit that data, or people not get your, but, so, there are other things that we can do to assist with that.
Just to add on, I really like the idea of asking the users, what they need. And I think in that conversation, if they can be prepared about how to use it to impact. I mean, I know it's making a difference in crisis aversion for some folks that continually decline. So I think being able to hear from the users how they're using it, health plans following up for faster follow-up care, just things like that, big reproductions, anything that, I don't know how much they have data-wise, but I think that is an important component to keep in mind. And then, how do these factors feed into that? Does a longer retention period matter? I don't know the answer to that. So that'd be helpful.
And the other thing I would really like to hear from those folks is concerns, acceptance or disacceptance of moving from the Florida-centric model to the national. I think that's a big leap. And again, I don't feel like I have a stake or a say in saying what the implications of that are. But I'm sure to an end user, they're going to say, oh, that's great, or oh, that's terrible, or maybe something in between. I don't know.
It's been great feedback. We really appreciate it. And it's very helpful to us. Thank you. If you think of anything else, email me. It is. All right.
So what we have left on the agenda then is just a quick recap for the conversation we just had on the HI vendor transition. Then we'll go into Craig doing the Hayek report. We've already had the DCF update from Molly, who has been here a lot more than we expected her to be. And then it's just public comments and meeting summary. And our next meeting, just wanted to confirm it's the 7th.
December 7th.
Okay. So it should be quick.
Because we already did the.
Do we still have Alexis on the line? So we still have quorum?
Can you look, Uden?
Yes, I can see.
So I think she was the only.
Oh, actually, we got additional, because we have Lindy and Jared Fowler
Oh, okay. I
on
didn't
there,
know
so we
that.
did get more members. I'm sorry, I should
Oh,
have
okay.
voted that, so we definitely have. a
I'm sorry, so
quorum.
you got Jared and you got,
Lindy.
okay, all right.
Sorry about that.
So, well, we might want to ask the 3 advisory council members who are online. You know, it's hard, I know, to break
Specifically,
in.
yeah.
So let's go ahead and do that when we start back up. I think this is one of them. And they're able to be unmuted.
They should be, yeah, they can unmute themselves. I believe they should be able to, right? Susan?
Yeah.
Is there?
Okay, all right. Well, so Pam, let's go ahead and.
Okay. Yes, I'm gonna go back to. Okay.
All right, we're gonna go ahead and get back on here. So we have a few advisory council members who are participating virtually. So since we did roll call, I understand Jared is on, and also Lindy and Alexis has been on since the beginning. I know it's really hard to break in to our discussions when we're here in the room and you're attending virtually. So on this HIE vendor transition, did you have any thoughts? Did you have any questions? Just want to make sure, you know, you got a chance to speak up. And
They can unmute themselves.
they can unmute, you can unmute yourself to do that. Are you on? Let me just check. Lindy, are you on?
By phones, I think just a star six.
Oh, so Lindy, you'll have to do *6 to unmute if you're just on the phone. Jared, are you on? Alexis?
I'm here.
Okay, did you have any questions or comments, especially on that last discussion?
I don't at this time. That doesn't mean I won't later, but not right now, no.
Okay, just wanted to make sure, since I know it's challenging to cut us off here in the room. And Jared, can you hear us? And Lindy?
I think Lindy, it looks like Lindy had to leave.
Oh, okay, okay. I would imagine that she has some thoughts and considerations about it, so maybe the ACA team could reach out to her.
Okay.
I would think she would have some thoughts on it, since she did when we were doing the addendum.
Hospitals.
Right, right. Yeah. So what I wanted to do before we go back, go forward on the agenda, just on this HIE vendor transition, just wanted to make sure we were hearing from all of the council members who are participating. But can we just clarify what the next steps are, you know, and how this is going to be approached? So we have a legal work group meeting coming up. And what are the specific issues and questions that we want them to address? And are they getting any information ahead of time? So
They will get information, the materials ahead of time. It was our intent to provide them with a copy of the current ENS agreement that includes the addendum that was approved previously. And then also to cover, now that we have a better understanding, cover the issues that we talked about today, the issues with having to change the consent model, looking at
Data retention.
data retention, and there's another one. There's
indemnification, in case there's a breach,
indemnification, but there was something else.
Commercialization.
to restrict the commercial use of the data.
Something that we did not bring up.
Well, we had the opt-in out discussion. I don't know, that's not really
That was
the
the
work group,
consent.
that's,
And I would add,
there's a lot in the consent piece.
we touched on a couple of, laws and regulations that this might run afoul of. So if those could be presented to that group so that they could really evaluate that, because that seems like an opportune time not to get caught later on and be sorry for having done something that we were unaware was inappropriate. Does that make sense?
Are there specific laws that you were thinking about?
No, anything that would prevail. I mean, we talked about data retention, that there's definitely stuff in regulation and statute about that. There's stuff about data storage. There's stuff about, I would assume there's privacy indemnification. Some of the things we mentioned, but instead of just talking blue sky, I think it would be beneficial for that group to have whatever is the prevailing Florida regulations or pertinent law.
We'll definitely do that.
Here, are there materials from the previous legal work group?
The legal work group has not met in several years. We're reestablishing the legal work
But
group.
I think when they did meet, they addressed some of these issues at the time,
For this.
just in general. privacy
Yeah, in
and things
general,
like that.
yeah.
So I mean, just, if there's any materials from that, you can give them just so they're not starting from scratch. That would be helpful.
So then regarding the Hayek then, so in advance of that meeting, we talked about getting some input from users through a survey, and we talked about, what data are you using, how does retention length factor in to the use of the data, what else do you need, just those types of questions. But I think we also had what impact going from the Florida centric model to the national model needs to be in there. And also we said, let's get some IT folks from the healthcare systems, from the hospitals to attend that meeting, give them, they're guests, but let them provide input. They're not necessarily appointed to the Hayek, but also at that Hayek meeting to make sure whatever comes up at the legal work group, they're updated at the Hayek, because that's going to impact their discussions as well. So are we leaving anything out? That's a lot. It's a lot.
Okay, so for the legal work group, the council recommends that in addition to having the information we provide, we'll have that laundry list of specific issues that the council wants them to consider. And then also making sure that we have the laws and rules that may impact this transition, including laws and rules around data retention, and sharing of information, those types of things. We'll definitely make sure that's available. For the Hayek, we are going to make sure that we get input from users prior to that meeting to share with the Hayek members and look at, specifically looking at any impact of the move from the state model to the national model for those users, and then also to invite some of the ENS users to the Hayek meeting, and meaning data sources as well as subscribers.
So I would also consider making sure it's clear when you talk about state model versus national model, that it's very clear that you're talking about point-clicking cares model, because this is not, when you use the terminology national model,
That's why I asked
that's
earlier.
confusing with the e-health exchange, the national health exchange. That is not what we're talking about. So I feel like we need to be very clear when we're communicating that, so.
Okay. Which is why I asked, because I wasn't clear. So instead of saying the national model, maybe
Point-clicking cares.
point-clicking cares, national footprint, or whatever,
It's their system.
Yeah.
Yes.
Yes.
So when is the Hayek meeting?
November 4th?
In November.
It is in November.
I think it's the 14th.
Okay, and you said legal work group is October 10th. Are you able to share the invitation to the legal work group meeting with us so we can listen in if we're interested and available?
And the Hayek,
And Hayek too?
and is that gonna be in person? Is that a 2 hour? Is that?
The The legal work group is virtual,
The legal work group.
it's
It's
both,
like this.
like this. So in person or virtual. if
But
you
it's
can't
only
in
probably a
person.
couple hours.
It's 2 hours.
And then the Hayek,
2 hours virtual.
so see, I feel like that might be one that, especially when you're bringing in representatives from the large health systems and their IT systems to discuss, that might be one you need more than 2 hours. And
Fortunately, we have Craig Dalton that chairs the Hayek that's gonna do a report next. That we can talk to about maybe expanding the length of that meeting and maybe doing it in person and virtual as well, because I think that one is typically virtual.
Okay. All right. So then, let's move on then to the Hayek report. And Craig, have you been able to hear all this conversation? You unmute yourself. Are you here?
Yes. Can everybody hear me?
Hi there.
Yes.
So maybe let's do those questions first. Would you be open to having the Hayek meeting that is already scheduled be maybe a little bit longer, since there's some heavy duty stuff to talk about, and also willing to do it as a hybrid?
I think that would be super smart to make it a 4 or a half day, because that's a long discussion. And
It sure is. Okay.
And I prefer in
So-
person if possible. If everybody could make it, or most people could make it, it would be great to have it in person.
Okay, so
So we want to move the Hayek to in-person?
And expand the time frame.
okay, so thank you. So we'll let you do your report, or did you have a question? Okay, let's get a question first.
I just wanted to make sure we hadn't lost, I think it was all of our collective idea to get a lot of the stakeholders, literally, physically. However, first maybe with this, a blast kind of questionnaire and make it really specific, but also get their live input, because to me, this is going to rise or sink based on their feelings about adaptation.
That has been captured.
do the meetings need to be held in Tallahassee, or can you put them centrally located in the state to make it easier for users to participate? I'm just
They do not have to be in Tallahassee. However, the chair of the Hayek is in Pensacola.
Oh.
And so really centrally located for him and people like would be here.
This is worth asking, right, Diane?
I just think of the Miami people.
Yeah.
Yeah.
Definitely.
And South Florida people, that's, it's a difficult, it is.
Yeah.
It's tough enough 4 hours from Orlando, so I know.
All right, Craig, I'd like to hear your report.
Okay, well, our last Hayek meeting met in August, and as I mentioned at the last SHIP meeting, I said we're going to explore a couple ideas, and you asked for a report back on how that meeting would go, and in this case, we're talking specifically about behavioral health. And one of the, just as a little bit of background, I asked Pam and Jamie if we could look at different areas of data and data points and continuity of care as opportunities for us to expand kind of what we think about at the Hayek. And one of the ideas right out of the gate was behavioral health. And so at the last August meeting, we invited Representative Michelle Salzman. She's District 2, is really spearheading an effort in the in the Panhandle, and then Jennifer Grove with Baptist Healthcare. She's Vice President for External Affairs, and then the Director of same system, Director of Behavioral Health, Eric Rutledge. And what we asked them to do is essentially, let's provide a baseline of what we're talking about with the rest of the committee, so that we could all, if we're moving, looks to me like November, we're not talking about it at all. But but the idea was at least baseline one meeting, so everybody has a good feel of behavioral health, what's this task force is doing in Pensacola and how Pensacola could represent other communities around the state of Florida. And so we asked them to do a presentation on that. And and based on what the findings were, and I can describe that just a little bit, but a lot of them, quite literally, were just functionality of, what to do with non-Baker Act. How do you collaborate and coordinate a really system of support services for behavioral health? Not just the Baker Act, but also the walk-ins and so forth. So that was one of the big findings. But what that opens the door for the Hyatt committee is, okay, well, what are the data points that we need to consider that are not being considered right now that would help a clinician, help a case manager be a better provider, and so more importantly, better patient care for those. And so the data points that these are folks, and I am amazed by this. There are so many people in that care system that, oh my gosh, can I pause just for a second?
Yes. I know he's scaring me.
I know, okay?
You okay?
I can have you call me back. I just got a text message. You want me to have you call?
Okay, so not sure what happened here. Are you back? Okay.
I'm back. One of the dangers of living right next to a naval air station is when fighter jets decide to.
Did it get loud? Okay. All right, as long as you're okay. We were wondered if you were in the car or something. Okay.
We've been in this meeting for 2 hours and 12 minutes, and that's the first jet. And so, of course, it comes when I'm talking.
All right. Well, glad you're okay.
Well, so what I was saying is we are amazed by how many people are part of the care and they don't have any access to data, or they have a lot of relevant data, and how do we pull that in to a community health record that everybody can have access to? So these are the things we're really diving into, and that's where we wanted to baseline the HIAC. It was much better received than even I imagined. I think anybody that was part of that would also agree that everybody, we had lots of great questions, but I think from the HIAC standpoint that we would want to pursue more of these type of, specialty. I call it specialty, but it's something that's affecting everybody. And so the better we can start understanding what are these data points and then start advising ACA, which is what we're out to do. So that is essentially the report. If you have any questions on that, I can go deeper, but I just wanted to say that it was super well received. And I think we're going to continue to pursue that at the HIAC, and we're going to come up with other areas in the continuity of care that we can explore to provide, better data for the caregivers. But this is where we're starting here, and like I said, I think it's the most difficult and the least known.
Okay, any questions? From anybody? No. All right, but Craig, I'm thinking we might overload you with important conversations about the HIU vendor transition as a top priority. So a hefty list there of issues to tackle.
Yes, clearly.
Yeah, we just wanted to make sure you were on the call for the lengthy discussion. Were you able to hear all that?
Yes, I was. I did hear everything, and that I think the right approach right now is to get the legal work group looking at some documents, and then I think what Diane said is have, health systems or other providers participate in the hike discussion. Because that's going to be a lengthy discussion, so we can advise you.
Right. Yeah. Okay, all right, we just wanted to make sure. Thank you so much.
Okay, thank you.
Okay, did you have a question, Diane?
No, Craig, the meeting is November 14th, is that what you said?
I didn't say the 14th, but it probably is. I had the 10th
Okay.
written. I don't know why.
And so I think, but you did encourage it being in person and
Longer.
So I think, are you looking like at 10? Starting at
Like
10?
a 10 to 2 kind of thing? Yeah.
Okay. November 15th.
Sorry,
That's what it is
15th.
currently scheduled for, but we will get with Craig just to make
Okay.
sure that
And what
that's,
time is it scheduled for now?
it's scheduled from 1 to 3
Okay.
currently, but we'll get with, it hasn't been noticed or anything.
Oh, okay,
So we
it
can
hasn't.
get with Craig and,
Adjust that.
adjust that.
Perfect.
if we need to.
Thanks. Okay, terrific. Thank you.
But that brings.
All right.
Oh, okay.
What's that?
Well, I was just going to ask Diane this. This meeting here started at 10. Most people that are driving up, did you stay overnight or did you leave at 4 o'clock in the morning to make this meeting? Because that helps describe.
I'm old, so I stayed overnight, and we'll drive back today because of the 4 hours. So yes, starting at 10 would be the earliest.
Right, right.
Earliest,
Because if you do leave from the Orlando area, it's a solid 4 hours. And then think about
Coming
people
from
from South
Miami,
Florida, they're
I
gonna have
know.
to fly in.
if they have flights and what those
Yeah.
things are.
Yeah, so I would say the 10 to 2, we've done that for this group
That's the
for,
latest.
Yeah. yeah. Okay,
Earliest.
earliest, yes.
Thumbs up.
Eastern time, 10 to 2. You do have
Yeah.
folks in Pensacola apparently on a different,
Oh.
different time zone.
Anyway, you always can start it at 1, and then people can make a decision on how to
Yeah,
return.
That's up to staff.
yeah, if you want.
We'll,
See who's availability.
we'll work with Craig to get the
Yeah, and just
time
make
and
sure you
right
get
and,
optimal, maximum.
yes.
Okay, great, thank you. All right, so Molly did get called away, but we did get her update at the top of the meeting. So we are at the public comment time of the meeting. So I wanted to give some instructions on, we don't have anybody in the room that's public, nobody hiding in a corner that I can see. Anybody online?
So, Susan, can people
So
raise their hand to?
could you give instructions on what they need to do if they're online?
If you have any questions, you can chat it in the chat box. Or if you are a member attending online, you can unmute yourself to ask this question.
Can we not unmute?
But for public comment, they should be able to,
Yeah.
even if they're not
They
a
can-
member?
They can there's a raise hand button on the
Yes.
toolbar and we can, we'll unmute, we'll
Okay, so I'm not
unmute.
sure if you heard that, so
Yes,
raise
there
your
is a
hand.
raise.
Yeah.
Yeah,
Sorry.
raise your hand using the toolbar on the top. And we'll unmute you.
So, doesn't sound like we have any public comment yet?
No.
No raised hands.
Okay. All right, so, thank you. All right, so, meeting summary. So, I wrote a lot of notes, and Pam wrote a lot of notes, so let's just make sure, I have a list of some action items, and so the first one I have is that we, obviously continue to think about what that retreat planning would look like, and to try to start landing on a date, but again, to my earlier point, we really need to get the positions filled that are vacant on the advisory council, so I do want to have that as an action item. Diane pointed out on the missing persons slide that we really need to have that reworded to avoid confusion, so that would be at the user level. we talked about a bunch of things with it. HIE showed the numbers of the data sources and the types of facilities, the types of subscribers. So that's some information to come back to this group. We were all very interested in the lunch and learns and an opportunity to look at the new website. So Jamie is going to send us calendar invitations, and we can choose to accept them or not, to be able to participate and see what's going on there. But also, if time allows, Pam, if we could have a copy of that chart that you mentioned that shows the suggested changes and kind of the status, whether they're happening in this phase 1 or if they are tabled to phase 2. That way we have that as advisory council members kind of off to the side as we're looking at the preview of the website. So we talked a lot just now, so we don't need to go over it on the legal work group and what those issues are that we're charging them to address, and then to have their discussion go on to the HIAC. And so also the charge to the HIAC regarding the HIE vendor transition as well. So I don't need to probably go through all of that since we just did that about 5 minutes ago. Also, if you could share the HIAC and the legal work group calendar invitations with us so that we could listen in if we're available to do that. There were a lot of different comments here and there, obviously, on this discussion about the transition. And one thing that seemed to be surprising was, you know, having the Florida Department of Health, you know, as a high user of, I guess, the ADT. So if for our next meeting, or maybe it's for the HIAC meeting, I'm not sure, but to share, you know, what are they using it for, you know, to what extent, because that would be really interesting information. It could be informative to us. And then that survey is really important to get out to the users, to be able to get a sense of certainly all the things that were brought up by Dr. Shapiro just now and earlier with, you know, how are you using the data? Will the length of time that the data is retained impact that favorably or unfavorably? What else do you need? You know, what do you like about this? But also that question about Florida to Florida switching to the point-click care national system, and to clarify that difference. And then the last thing I had was HIAC meeting being in person and a longer meeting. So that was my list of items.
Just a different slant on that penultimate issue, which is, I think those end users, if they are exposed to the checklist of things that this company would add, I think they need to tell us what it is they need.
Yes.
And not the other way around. So in other words, have them tell us what, because we're going to send an RFP or whatever the other term you use, but have them establish the criteria that they feel they need, so that whatever it is, they're going to be happy with it, regardless of which vendor we go to.
Yes. What do they need? What are they looking for? Definitely. And did I miss any action items?
Yes, one
We
item
didn't-
I had that we
Can
talked
you use
to.
the microphone?
Sorry. Yeah, so our team will reach out to Lindy for
Okay,
her,
good, thank you.
yes, opinion on HIE transition.
Thank you. Miss anything else? Pam had a bunch of notes too.
I think you got everything that I had.
Yeah, I guess I had one other thing. Let's swap out that, for the website, for the SHIP, to make sure we have the 2-page document on there rather than just the 1 page for this.
Oh, yeah, the meeting
Right?
material, we
And
updated.
just making sure on the slides, when you're sharing the slides, please make sure the action items were the updated chart that has behavioral health for the e-blast and self-funded versus self-pay on there. So those were also
And then,
some
yeah,
items.
and then the last one, of course, we just went over it, is to get with Greg to,
Yes,
on the date and time for the highway.
right. Okay. Lots of follow-up. So the next meeting has been rescheduled, so it is December 7th, in person with, virtual capability. It's from 10 to 2. So there had been a poll that went out for a couple of dates, and December 7th is the winner. Yay. Hey, good thing I'm gonna be in DC on November 30th. All right, so lots of things to happen between now and then. Is there anything else for the good of the order? Other than you're gonna look for your lunch, right?
We're gonna go buy it.
You're gonna go buy another lunch? Okay.
December 7th is 10 to 2 again? Or we
Yes,
don't know.
10 to 2 for December 7th, and please send a calendar invitation out.
And that will be without me. I'm pretty sure I can't even do it virtually.
Oh, no. Well,
Sorry.
so I would like to suggest, Dr. Shapiro, that you attend the prep call with me for this meeting since you can't attend. Is that something that we can,
No, I don't think
no?
so. 'Cause we
Can you
would
have a
to-
discussion separately with him?
Don't worry about me.
Because when I was vice chair, you would meet with Kim. First, Kim and I would meet with you. And then it changed for some reason with Sunshine where you would meet with Kim and then you would meet with me.
Okay.
So I'd like to make sure we have any updated thoughts.
Yeah, I think that's okay as long as we don't share any, as long as we don't go, well, Karen said. That's fine.
You figure it out.
Don't worry, we'll just go after ASCs while you're gone.
There you go.
Yeah, there you go.
On
On that note, I'd like to ask for a motion to adjourn the meeting. So, we have a motion to adjourn.
So moved.
Second. All right, all in favor, say aye.
Aye.
Any opposed? All right, thank you, everybody. Take care and safe travels if you're heading out.
So I'm gonna delete that 14.